And I'm really happy we have Michael Hengartner today, who'll be talking about antidepressant withdrawal. I think we are really lucky to have him here because he's running down with a virus and still doing the talk, even though he's really not feeling too well. So we are really grateful for that and glad to have him here and able to hear his talk. And I have to admit, before this talk, we had a lot of discussions about terms, probably the first time in the years of the conference that we struggled so much. And we struggled to find some translations for the terms and consulted both clinical toxicologists and addiction disorder specialists what to do with that. And we're really grateful for all the advice we got. And actually, the difficulty is that in Lithuanian, you have one word for dependency and addiction, priklausomybė. And then kind of in meaning of the word is more in line with the term dependency rather than addiction, even though we use it for both in Lithuanian. So dependency in here will be called fizinė priklausomybė, like bodily adaptations associated with use of substance or medication, and not in terms of addiction that it's sometimes used in terms of loss of control or intense urges despite adverse consequences. So these two words, dependency and addiction, are sometimes confused even in English, where we have two words. But it's even more confusing when we have one word. And it's similar what difficulty was with the term withdrawal. We'll hear more about this in the talk, but we just wanted to say that in here, the term withdrawal will be translated as abstinentia, not in terms of craving, that this word is sometimes used in addiction settings, but in terms of actual physical symptoms when a substance is discontinued and not used. So just kind of a preface about the translations of this whole issue and this whole topic. And I want to introduce now the speaker who will be speaking more about antidepressant withdrawal symptoms, and Professor Michael Hengartner, who is a senior researcher, lecturer, and counselor, and also a clinical psychologist at the Zurich University of Applied Sciences. In 2018, he received his habilitation in medicine, psychiatry division at the medical faculty of the University of Zurich. And he has multiple projects in social psychiatry, psychoendocrinology, antidepressant use, and psychotherapy. In 2022, he published a book called Evidence-Biased Antidepressant Prescribing, Over-Medicalization, Flawed Research, and Conflicts of Interest. We know this is a controversial topic, but it's a very new and important area to talk about because otherwise a lot of important questions are missed. So we are really happy to have you here and hear you talk about it. So thank you for being with us, Michael.
Thank you very much. And thank you for this very kind introduction. So as you might already hear, I'm truly sorry. I apologize for being sick, but I try my best to get through this. All right, so now you probably see my slides, huh? All right, so yeah, as you may know, or I have heard before that this is the first time actually in Lithuania that you talk about antidepressant withdrawal. And in fact, it is true that in many other countries, there has just in very recent years been growing interest and attention to this topic. And it gets also increasingly acknowledged in research, education, and practice. So we might wonder, okay, is this something that is new, that we just discovered very recently? Well, in fact, that's not true at all. It's nothing we just discovered recently. So why we just start addressing this now. In my view, the main reason is because of denial and dismissal of this topic and ignorance. So I give you a few examples why I may come to that conclusion. Here is one study published by Kessing et al. In 2005 that was in a very prestigious psychiatric journal. They conducted a survey among inpatients on antidepressants to ask them or provide them different statements and the patient statements about antidepressants, and the patients had to respond by saying I totally agree or disagree. And there were different questions, but very interesting. So there was one question if they find it difficult to stop antidepressants when they have taken them for a long period of time, and 57 of the antidepressant users endorsed this statement, and a similar figure, 56%, they endorsed that I believe that your body can become addicted to antidepressants. So seeing these results, one might conclude, okay, well, we have not been aware, but it seems that people may develop some kind of physical dependence, and they may have difficulties when they try to stop antidepressant treatment. But that was not the conclusion in the paper. The main conclusion was that a large proportion of patients had erroneous beliefs regarding the effect of antidepressants. Although all these subjects have been treated in hospital settings, they still had major ignorance and negative attitudes, suggesting a need for intensified psychoeducational activities. So that's how these authors, and this were a group of very senior psychiatrists, academic psychiatrists, that's how they interpreted these results. Another example is there was an article in Lancet Psychiatry. It was not in the Lancet Psychiatry, but Peter Gucci published a paper discussing the benefit-harm ratio of antidepressants. And at one point in this paper, he also stressed that many patients experience serious withdrawal difficulties, and some cannot come off antidepressants because of that. And there was a response by quite a large group of leading academics from the UK. And that's how they addressed, for instance, the part on these withdrawal difficulties. So what they wrote in the paper is, in our experience, the vast majority of patients who choose to stay on them, so on antidepressants, do so because they improve their mood and well-being, rather than because they cannot cope with withdrawal symptoms when they stop. Many of the extreme examples of adverse effects given by the opponents of antidepressants are both rare and sometimes sufficiently bizarre as to warrant the description of an unexplained medical symptom. So I could go on like this. So, but you get a sense how in academia the topic of dependence and withdrawal was largely refuted or dismissed, and one may even say denied. And this is also something that patients or antidepressants user will experience. So if you conduct a survey among antidepressants users, you will see that many of their complaints regarding withdrawal symptoms are largely, mainly dismissed or ignored. So here we have one survey conducted by Guy and colleagues in 2020. And so in their sample, 9 patients sought help because of withdrawal symptoms when they tried to reduce the dose or stop treatment. So they responded that 12% responded that the doctor denied that the symptoms were related to withdrawal. 15% responded the doctors were helpful but inaccurate. And according to 42%, doctors were unhelpful and inaccurate. And only 1% of antidepressant users responded that they considered their doctor helpful in this regard. And another survey also showed, for instance, that if you inquire antidepressants whether they have been informed that stopping treatment may cause difficulties, whether termed as withdrawal or as a discontinuation symptom. According to this, that's one of the largest survey ever conducted. Just only about 1% of users remembered that they have been informed about potential problems that may emerge when they try to stop treatment. So my voice is getting worse and worse. I hope you still understand me. Okay, and of course, then a few years ago, research, as I already said, there was a growing interest in this topic, but that was actually not met with interest, but as I already said, actually more with defensiveness. And then here is just a selection of a few papers published in leading outlets, and these are just the title of the papers, but they all address actually these were actually responses to either scientific papers or media reports about antidepressant withdrawal. And you already see what kind of response that provoked in many leading academics. So one paper was titled "The War on Antidepressants," and Norton colleagues, in their title, they said, "Attacks on Antidepressants, Sign of Deep-Seated Stigma." And also Perlis, former editor-in-chief of the American Journal of Psychiatry, he wrote a commentary where he complained that journalists or researchers stressing or endorsing the problem of withdrawal, that they have anxiety about antidepressants. Part of one important factor that contributes to this refusal or ignorance lies in the term that we use. So as you have already heard, in some languages it's not even easy to differentiate withdrawal or discontinuation. And here I also demonstrate that antidepressant withdrawal, in fact, is nothing new. It actually has been known for decades. It's just that it has been actually rediscovered and now is taken seriously, at least in some quarters, and finally gets the attention and that it needs in research, education, and practice. But it's been known since many years. Shortly after the introduction of the first antidepressants, there have already been scientific papers, especially case reports, who alerted physicians to the problems that may emerge when patients try to stop antidepressant treatment. So you see there have been papers. There are many more, but I just reference here a few of them to make my point. So you see one was from 1961, that was just 1 or 2 years after antidepressants were introduced in clinical practice. And it was also more comprehensively studied in the 80s. For instance, there is quite a comprehensive review by Dilsaver and colleagues from 1987, where they also proposed pathophysiological hypothesis, why withdrawal symptoms may emerge in some people and in others and on. And most importantly, these papers were all before the selective serotonin reuptake inhibitors were introduced into the market. And in all these papers, they all use the term withdrawal symptoms, withdrawal syndrome, or withdrawal reaction. The term discontinuation syndrome was not even known back then. So until the 90s, it was always clear that this problem is withdrawal. And it has always been termed like that. So why did that change? So what happened? So as you all know, in the 90s, the SSRIs became blockbuster drugs, and they were among the best-selling drugs of all medicine. That had several reasons. One of them, of course, is clever marketing, but another is that with the introduction of DSM-3 in 1980, and the concept of depression changed markedly, and what was formerly mostly termed anxiety neurosis and neurotic reactions, and they have been retermed as depressive disorders, specifically major depression. And because of that shift in diagnosis as well, and in the diagnostic concept, what was previously treated with benzodiazepines, because these were considered anxiety conditions, then they were newly conceived as depressive disorders. So then they fell into the therapeutic domain of the antidepressant drugs. And that's also when the SSRIs largely replaced the benzodiazepine in these conditions. Moreover, in the early 1990s, because the depression market was actually quite saturated already with many Me Too drugs introduced into the market back then. So after fluoxetine, there was paroxetine, there was sertraline, and so on. So all these SSRIs had to combat for market share. So then the idea emerged that the companies seek a license. That means an approval of antidepressants for the anxiety disorder, so that it again enlarged the market of antidepressants. And with that new class of drug actually replacing the best-selling drug of the previous era, that is the benzodiazepines, there was a problem. Because benzodiazepines were widely considered dependence forming, and it was accepted that they can cause serious withdrawal reactions when patients try to stop them, especially when they have been used for a longer time. And so the pharmaceutical industry feared that the label of dependence and withdrawal could also be attached to antidepressants. Because the SSRIs basically replaced the benzodiazepines in many therapeutic domains. So for marketing reasons, the pharmaceutical industry in the late or mid to late 90s, they introduced a new term, and that was effectively disseminated also by many key opinion leaders, that is, and that's mostly leading academics that also have financial relationships with the industry, serving as consultants, speakers, or advisors. So that means that this new term was effectively disseminated, but it was actually an invention in the year 1996. It was completely inexistent before. So what was previously always known as a withdrawal reaction, the problems, the symptoms that emerge when a dose is reduced too fast or abruptly stopped, and which is still actually the term that was used, for instance, for benzodiazepines. Then suddenly for SSRIs, it was proposed for the SSRIs, we don't use that term anymore. We use the term discontinuation syndrome. So that's where this new term was born. And it replaced, at least in the domain of antidepressants, it almost completely replaced the term withdrawal, because starting in 1996, the few articles that addressed the issue, then suddenly they did not use the term withdrawal reaction anymore, but the new term discontinuation syndrome. And this has changed already. Now there's again the movement away from discontinuation, because it has been acknowledged that this is just an invention, and it has always been known as withdrawal. And it is also known as withdrawal with many other drugs, prescription drugs, and illegal drugs. So that's why now most experts agree that withdrawal is the most appropriate term. Another problem concerning concepts and terms is the distinction between dependence and addiction. They are often used interchangeably in common language in English, but in pharmacology and addiction medicine, they have very specific and distinct meaning. And this is very important to understand what may happen when people experience difficulties when they stop antidepressant treatment. So on one hand, we have dependence, well, sometimes also termed physical dependent, to make clear that this is a physiological process. So dependence arises when body and brain undergo adaptations, that means changes, to the presence of a drug to counter the effect of the drug over time so that the body can maintain homeostasis. So what are these adaptations? So one, for instance, is serotonin receptor downregulation. So that's how the body responds to a substance that increases serotonin levels massively. So the only evidence actually of a state of dependence is, in fact, the appearance of withdrawal symptoms on reducing or stopping the drug. So simply put, dependence is mostly or merely a physiological reaction to prolonged drug exposure. On the other hand, what is addiction? I'll come to addiction later. Here is a statement, a shared statement by the American Academy of Pain Medicine, Pain Society, and the American Society of Addiction Medicine. So that's the official definition by all these influential societies. And they clearly state that physical dependence is a state of adaptation that is manifested by a drug class specific withdrawal syndrome that can be produced by abrupt cessation, rapid dose reduction, decreasing blood level of the drug, and or administration of an antagonist. So now I'll turn to addiction. What is addiction then? Again, simply put, addiction means that someone craves a drug and cannot control its use. So people go on to use the drug despite negative consequences. Thus again, addiction here in that sense is primarily a psychological reaction. This is also why we can become addicted to all sorts of things, not just drugs. We can be addicted to many non-pharmacological things like shopping, games, sex, gambling, you name it. So this is clear that addiction does not require actually that a physical substance is introduced into the system. And this is important because people who are dependent, physically dependent because the body has adapted, because when people are dependent on a drug or medicine, they aren't necessarily addicted. You can be dependent physically to many substances. You can be dependent without being addicted to them because you don't crave them, you don't abuse them, you don't have, you don't show patterns of uncontrollable use. So this is important because antidepressants do cause dependence in the sense that the body adapts to the drugs. It's a physiological adaptation. So in that sense, they of course do cause physical dependence, but they are not addictive. No one craves antidepressants and shows uncontrollable use. So then why is there such confusion between dependence and addiction if in pharmacology and addiction medicine, there's a clear distinction between the terms? Well, actually, the main culprit here is the diagnosis of dependence that was introduced in 1987 in the text revision of the DSM-3. So what happened there? Starting with the DSM-3 text revision, addiction and dependence were conflated. why the committee, the committee, the diagnostic committee, argued that the word addiction is pejorative, because until the introduction of DSM-3R, addiction was always named addiction. But then the committee decided the term is pejorative and dependence would be more neutral. And then they had the brilliant idea, so let's now call dependence addiction. Let's call addiction dependence. So now, introduced in 1987, the term dependence was thus used to describe uncontrolled drug-seeking behavior that was previously always termed as addiction. So here a statement by O'Brien, that's a very leading senior addiction researcher, and in an influential paper, he clearly states, there is a normal physiological response called physical dependence, and there is addiction, which is drug-seeking behavior called dependence in the DSM. So it's actually absurd, but there we are. We have a condition, a diagnosis that should be addiction, that was retermed as dependence, but actually means addiction. So don't blame psychiatrists or doctors if they confuse dependence with addiction, because this confusion was introduced with the diagnostic manual DSM-3R. So now some words about the phenomenology of withdrawal. So there have now been different studies and meta-analysis, and the best estimate is that withdrawal affects about 30 to 60% of users when they try to stop antidepressant treatment. And it involves various mental and physical symptoms, but the most frequent are, and you see that this is a mixture of physical and mental symptoms. So we have dizziness, that's actually the most frequently reported withdrawal symptom. Then electric shock sensations, usually known as brain zaps. Insomnia, then we have irritability, agitation, anxiety, nervousness, low mood, bouts of crying. So you see that this discriminating withdrawal from, for instance, a depression relapse can be quite difficult if you rely merely on the presentation of these symptoms, because except, for instance, dizziness and brain zaps, all the other frequent withdrawal symptoms may also be part of a depressive disorder. But there are clear indicators that help to discriminate withdrawal from relapse, and you need to consider the timing, that is the onset of these symptoms. And if this is closely linked to reaching a low drug level, then it's of course more likely that this is a withdrawal rather than a relapse. Then also the quality of the report as the subjective quality, because patients experiencing withdrawal symptoms, they almost everyone says it feels different than my depression symptoms that I had before, or these are symptoms I never had before, they are more extreme, or it's just that has a different quality. And important is also the response to medication, because acute withdrawal symptoms often disappear instantly, in many cases, not in all, after reinstating the drug or increasing the dose. And so that close correspondence between drug level and appearance and resolving of symptoms makes clear that it is a withdrawal reaction and not just a relapse. But that's also a wider problem, why antidepressant relapse prevention trials are prone to serious confounding. And because in these trials, usually antidepressant treatment is stopped abruptly or rapidly, and then half of the sample receives a placebo instead, and the other continue with active treatment. And then relapse is usually assessed with depression symptom scales. And as you all know, what kind of symptoms do these scales include? So of course, what we rate is low mood, nervousness, anxiety, agitation, insomnia. So how do we know actually that this is a depression relapse or a withdrawal reaction? Because there is huge overlap between the symptoms. One way to address this is to study what happens if patients in remission of depression, and these have been in remission for many months, and if you substitute their antidepressant drug, unknowing to them, so blind, for a few days with a placebo. So they don't even know actually that the active drug has been interrupted there, because they take a placebo that this looks completely the same. So then you can look closely what happens then as soon as the active drug has been stopped and replaced by placebo. And what happens is that these show a huge increase also in depression symptoms, and if you score them with like a rating scale, like the Hamilton depression scales, it yields a prevalence of 27% of depression. But of course, because of this design, we know that this is not a relapse, it is a withdrawal reaction, especially when after 5 to 8 days of interruption, if the active drug is reintroduced, all the symptoms, including the depression symptoms, they disappeared altogether. Because of course, it was not depression, it was withdrawal, and withdrawal responds closely to drug level. So again, if you look at these trials, so I make this rather short because that's actually not the main point. But if you look at what happens in relapse prevention trials, you see that actually most events, so putative relapses, occur within the first 6 weeks of treatment discontinuation. And after and that, what happens in these first 6 weeks accounts for roughly half of the full effect that is shown in these trials that may last from 1 to 2 years. If you look at after 18 weeks of treatment discontinuation, and you look at the placebo arm and the drug maintenance arm, you see that placebo prevents relapses as good as effectively as continued drug treatment. So that means after this rather short time period, shortly after stopping the active drug, if you look a little bit further, it makes no difference anymore. And that strongly indicates that continued drug treatment presumably prevents withdrawal reaction rather than genuine depression relapses in many cases. So graphically, here you see when people stop the drug, when do relapses or what is assessed or considered a relapse occur, you see that this, and the steeper the line, the more of the total effect is explained. And you see, if it was relapse, you would rather expect a constant increase. But here we see a massive effect in the first few weeks, and thereafter already 100% of the effect is achieved, and then it makes absolutely no difference whether you take placebo or an active drug. So about the neurobiology, what we know due to several studies is that antidepressants lead to neurophysiological adaptations in the brain within a few weeks, and these adaptations are assumed to play a role in withdrawal. So specifically, with various neuroimaging PET studies have shown that during SSRI treatment, the body downregulates serotonin receptors in the brain. It has been replicated many times. So this is actually an accepted fact that once you take the drug, after a few weeks, the brain will adapt to that. And that means if serotonin is increased, well, let's decrease serotonin receptor sensitivity or even the activity. So what we see here is we see the blue line, that is the drug level, and the serotonin, the assumed serotonin level in the brain. So what happens if you start taking an antidepressant? Of course, serotonin level increases instantly after a few hours. It increases because we know the body will respond to that. And it starts to build up adaptations. So here in that specific case, that is meant to show that the adaptations, they align with the increased drug level. And so these adaptations are desensitization or downregulation of serotonin receptors. And that's fine as long as the drug level is constant. But if the drug is then stopped rapidly or abruptly, serotonin level falls below the level to which the body actually has adapted. And this is leading to a disequilibrium in the brain until these adaptations have resolved. And that's what's happened here. You stop a drug level falls quite fast, depending, of course, on the drug elimination half-life, but usually within a few days, the drug level is close to zero in most drugs. But what does not resolve that fast are the physiological adaptations. So that means, for instance, the downregulation of serotonin receptors. So if the drug level is low again, or at normal, at baseline level, then suddenly the brain actually needs to readapt. That means that it needs to reverse these downregulated serotonin receptors, but that goes not as fast as the drug level falls. And this is the period where people may experience withdrawal symptoms. So important now, of course, there may be many different factors, but one important factor surely is presumably serotonin. So if we look at what do SSRIs do in the brain, we see, of course, they block the serotonin transporter. So how effective is this? So already with the minimal licensed dose, you see that here, for instance, with citalopram, about 75% of serotonin transporters are occupied. If you increase the dose, that actually does not make that much of a difference. So maybe then it's rather 78 to 80%. It's also the reason why increasing actually the drug does not result in increased efficacy, because pharmacologically it makes no difference whether you have the minimal dose or a very high dose. Serotonin receptor is blocked almost identically. So that's why you cannot, the only thing that increases are side effects rather than efficacy. Same with fluoxetine, minimal dose, 20 milligrams. And if you increase that dose, you'll see that already with 20 milligrams, you have almost 80% of occupancy. And if you increase the dose, it stays quite the same, so a little bit above 80%, but it's basically almost the same. But where things change drastically is when the dose becomes very small. So way below the minimal available dose, then that's where the serotonin transporter occupancy diminishes extremely. So that means that the biological effect is most pronounced at very, very, very small doses, because that's where it makes a difference. So whether you take, let's say, 2 milligrams or 10 milligrams, that makes a huge difference, as you see here, regarding transport occupancy. Whether you take 20 or 60, it makes almost no difference. But this has a huge relevance for understanding why withdrawal symptoms emerge, especially at very small doses. That's also why many psychiatrists say, well, there can't be withdrawal because the dose is so low that has no effect anymore. Well, it has no effect. And it has no effect in regards to antidepressant efficacy, but in relation to what they do pharmacologically, it makes a huge difference. So by consequence, risk of withdrawal symptoms becomes disproportionately larger at very low doses. That's the important message here. The risk is highest the smaller the doses gets. And the risk is highest at doses way, way, way below the available minimum dose. And that's also a practical problem, because there are not so small doses. So that's why patients, other users, some now increasingly start cutting, crushing and counting beans and whatever, or trying to have a liquid solution so that they can make these very small differences. So to avoid or diminish withdrawal symptoms, as we have seen before, that's a hyperbolic function. So that means we need hyperbolic tapering. And that means that you, to for the biologic effect to be constant, the dose needs to be decreased by smaller and smaller amounts. So for instance, in people who absolutely do not tolerate even the smallest dose reductions. So for instance, then it is advised to try 10% dose reduction, for instance, every 2 to 3 weeks. So we already see what that means. If someone is at 10 milligram, 10% reduction every 2-3 weeks means then after 10, it's 9, 8.1, 7.3, 6.6, 5.9, 5.3, and so on. So, but you see the absolute reduction gets smaller and smaller and smaller and smaller. And this is important because otherwise, if you take too large an amount, then you have a huge biological effect. And thus tapering in this hyperbolic way, of course, depending on where the withdrawal symptoms set in, may require months or even years in some cases, sadly. And many patients, they do not tolerate this at all, and they return on the drug because they just do not manage to stop it. So this is, again, I've shown this graph already, but here you see what happens when you start to taper very slowly with a hyperbolic taper. So as we have already seen, what we want to prevent is that the drug level falls so abruptly, because then there's a huge or a largely increased risk that withdrawal emerges. So when you make these small reductions constantly, then of course the risk of withdrawal is also reduced. So here is someone that may tolerate greater dose reduction, for instance, 20% or 25% every 2-3 weeks, whatever. And here's an example of a person who does not tolerate larger decreases. So here, for instance, that would be an example, for instance, of 10% reductions every 2-3 weeks. So that would then look like this. And look, of course, you start with larger reductions. If these are tolerated, very fine. But if you experience then very uncomfortable or unbearable withdrawal symptoms, that usually means, well, the dose reductions was too large. So if it was 20%, then maybe you have to go down to try out 15%, or if that doesn't work, again, maybe even smaller, then maybe it's just 10% dose reduction. So that's basically it. I will also rest my voice because probably also not so amusing to listen to that voice. But I thank you for the attention, and I hope that this was helpful. Thank you very much. And yeah, of course, they may have questions, right?
Thank you, Michael. If you close down your slides, we can just have a talk and see each other. So thank you for a very interesting presentation. When we thought about the program of the conference this year, one of the topic, antidepressant use within the suicide prevention, is an important measure of intervention for people who are suicidal and are struggling with depression. So we thought it's important to talk about how we provide an intervention, and we need to, then when the person is better, to stop it, and we need to know how to do that properly. And in Lithuanian context, I don't think we have spoken at all about antidepressant withdrawal and the symptoms people face. So it was for us an important topic. But this question was raised by participants, and maybe you have some thoughts on that. What's the relevance of what you spoke about for suicide prevention and suicide intervention measures?
Good question. We know now from several studies that not even large increases, but also large decreases in dose may cause agitation or suicidal symptoms. So that's why, because some people may really become suicidal due to withdrawal issues. So that's why it is really important to, if as soon as it's clear that someone experiences withdrawals and the criteria I need may help here, then it's return to the dose the patient was at and try to get slower and smaller reductions, but the basic thing that, okay, 2 weeks you need to take the minimal dose and then you can stop altogether. That may work for some people, but for many that's just very too fast, so that you need to go slow, really slow, and always check with the patient how he or she experiences then the symptoms or not.
Thank you. I know your voice is kind of pushing to its limits, but I'm really glad that you're still managing, and because it's really important for us. There's another question about there is no recognition of withdrawal syndrome in Lithuania or any medical guidelines through hyperbolic tapering, reducing withdrawal risk. I wonder if, according to your research and clinical practice, a protracted withdrawal syndrome would resolve itself with time if one is already experiencing it.
Good question. I think it's a shame, but there are so many questions we cannot answer because we don't know. We just don't know yet. So to address this question, we need to conduct the research, and there is no research into original research, almost no original research into protracted withdrawal. So that's why there's a lot of speculation and opinion, but there are barely data to answer these questions. So I'm really sorry, but I cannot answer that question. We don't know. So actually, the important message is we really need to conduct the research to answer these important questions, but we are far, far away from that. Yeah, there more efforts has to be done into studying not only the process of withdrawal and the neurobiology, but also prevention strategies. And especially also how is there pharmacological or non-pharmacological treatment for persistent withdrawal symptoms? We just don't know. There has never been a trial that attempts to answer the question, how do we treat withdrawal symptoms? So I don't know. We don't know.
Okay, thank you. There's another question on the link with suicidal behavior. One person asks, I've read that SSRI drugs may result in suicidal behavior for adolescents as a side effect. Mm-hmm. What is your opinion on that, and can you speak about this link?
Yeah, that's true. And that's well established. That's why there's a black box warning. So the FDA, for instance, the drug regulation agencies, they require the producer of antidepressants that they list suicidal behavior and thinking as a side effect. And this has been consistently replicated in many meta-analyses in adolescents and young adults, that the risk of suicidal events is significantly larger on active drug when compared to placebo. So that has to be a pharmacological effect. And so great care has to be, because usually many doctors think, a patient gets suicidal, so we have to increase the drug. But treatment emergent suicidality may be a side effect of the drug. So increasing the dose may make it even worse. And that's why it is important to carefully evaluate in a specific case whether this might be related to the drug. So perhaps rather than increasing the dose, test dose reductions to see whether the suicidal impulses then diminish. Yeah.
Okay, that's very important, and thank you. It's helpful to see that there are strategies to understand what's happening for an individual patient. Mm-hmm. There's a more general question. What holds the psychiatry system from moving to a less antidepressant focused approach?
I was wondering as well. Yeah, tough question. I don't think that is an easy answer to that, but the World Health Organization just published their revised treatment guidelines, mental health gap action program. So these are the new treatment guidelines for the World Health Organization, and I'm proud to be, I was part of that group. And in that guideline, for instance, there is an explicit recommendation not to use antidepressants as first-line treatment, but psychological therapies, and that drugs should only be considered in combination with psychotherapy. So that may be a starting point, but whether that has globally an impact, that's another question. So I don't think that this will put an end to ever increasing prescription rates. So yeah, basically, I don't know what it may mean.
Oh, thank you. I guess it is a tough one, hey. But there are a lot of positive comments coming, thanking you for the presentation, that it was important to hear and was very clear, helpful, and a lot of people are appreciating it. So I think it's important for you to hear that.
Thank you very much.
There are a few questions a bit more about specifically antidepressants. What could be a relation between antidepressants and suicide? What could be the mechanism for this relationship? Is there any research on that?
Yeah, very little bit, but basically there are two competing theories. One is that because we know that especially activating antidepressants like SSRIs or SNRIs, they may cause agitation, and in some people that may be very extreme inner nervousness, and to the point that it may be experienced as akathisia, and that this may then, as a consequence, produce like this impulsive suicidal behavior. And another, but these are just theories, just to be clear, another theory is that this has to do with one of the main effects of antidepressants, which actually is emotional numbing. So that's why they may be effective in some people, but because they numb your emotions, so people get less affected by negative emotions as well. And have more emotional distance, but this numbing may also cause maybe some people to be numbed too much, so basically that they don't care anymore. But these are just theories, but it's very difficult to establish what may be the causal mechanism between treatment emergent suicidality. That's difficult, but what we may agree on is that it is a side effect, but the mechanism is not entirely clear. But the most pronounced theory is that this is due to the inner restlessness, akathisia, that this may be the main mechanism, which is just a hypothesis.
Are you aware of any strategies about, I don't know, monitoring this, intervening with this, kind of preventing this from happening?
Well, of course, as already said, one surely efficient way would be to reduce the dose. And what is commonly or frequently also done is, of course, to add a sedative. So that's why also in the trials that were conducted by the pharmaceutical industry to get regulatory approval of the SSRIs, they were almost completely always prescribed together with benzodiazepines, because the producer already knew that SSRIs, even in healthy people without depression, they may cause inner restlessness, agitation. So to prevent this from occurring in the efficacy trials, they often prescribed benzodiazepine together, because especially exactly for that, to reduce the level of agitation. So of course a sedative may of course be an option, which already is common practice, of course. If you have strongly agitated suicidal patients, then usually use a sedative, and now mostly, of course, in neuroleptics we have very strong sedative effect.
Okay.
But I'm not a pharmacologist, so that's why that's not meant as clinical advice. It's just what I know from research. This is really important to stress, because I'm not a doctor of medicine, so I'm not allowed to give medical advice. That's just what we know from research. That's not my personal opinion. To get that right. Yeah.
Okay. Another question is about the possible effects when the person is taking antidepressants like they wish and regulate this use themselves, like they take antidepressants when they feel bad, stop taking when they feel good, and then start up again, or kind of this intermittent use. Do we know any what effects this could have?
Yeah, we know, and that's a very bad idea. Yeah, because then, of course, the drug level is decreasing massively, and that's absolutely not what we want. We want a stable drug level. So these drug holidays, for instance, some people use that to have sex, for instance, because of course sexual dysfunction is a very frequent side effect, and for some people the only solution to enjoy sex is to make a pause, a drug pause, but that may also cause problems, especially, and we know that because many patients already report them when they forget a dose, or when they forgot their pills at home, for instance, when they go to holidays, then suddenly they may experience withdrawal symptoms. For some people, it's no issue at all. That's another actually peculiar thing, that for some people they don't experience withdrawal symptoms at all. And for other, it's so severe that's unbearable, and we have absolutely no idea about why there is so huge variation. So there may be people who can, like say, switch or interrupt some doses, but I don't think that this is certainly clinically not recommended, of course. But they may not experience withdrawal symptoms, and for others, then as soon as the drug level falls, they may experience withdrawal. So best to keep it constant, of course. Yeah.
Okay, so these people move
also because of the antidepressant effect. If the drug is working for someone, especially if symptoms are still acute, then of course then it's not advisable at all to miss deliberately miss doses.
Okay. We have one more tricky question, I think, which could be the last one. Why did people make the DSM-3 so confusing?
Yeah, good question. Well, so excuse me. As I wrote in the slides, I really think that the intention was quite good, because the committee thought addiction is pejorative. It's stigmatized. So let's call it dependence instead. That's less stigmatized. So that was actually the intention, but it's absolutely what I cannot explain to myself is that these people should have known, or at least they could have consulted with experts in addiction medicine or pharmacology, that you can't just name something that was a concept dependent, that is a proper meaning. You just cannot switch to that because you don't like the term addiction. If you think addiction is pejorative, then you need a new term for addiction, but you can't name it just like that, dependence, because dependence has another meaning. Well, but that doesn't answer your question. Yeah, I think it was that intention to destigmatize, because substance use disorders are among the most stigmatized mental disorders, and that's why they wanted to avoid the term addiction. Yeah, but that was a terrible decision. But that's maybe that's probably the reason why.
Okay. Thank you. And I have to admit, there was one comment about withdrawal syndrome and calling it nutraukimo syndromas in the comments, that it should be called a discontinuation syndrome. And we are aware, I want just to say to the listeners that we are aware that it's the usual case here in Lithuania, but just because of what you spoke about, we thought it's important to still maintain this distinction in Lithuanian as well, and call withdrawal. Yeah. Abstinentia. So just a comment on that.
Maybe a final comment on that too, because I think the term discontinuation is even misleading, because people may also experience when they just lower the dose too fast. So it doesn't mean that the drug has been discontinued. It may also because they miss a dose, or because they reduced the dose steeply, even though the intention was absolutely not to discontinue, but rather maybe due to side effects, they want to lower the dose. And then that's why discontinuation is not accurate, especially in these scenarios, because that's not a discontinuation then. It's basically a lowering of a dose. What is always accurate is withdrawal, because according to the meaning that I explained, that the body response is in a state of physical dependence, which causes withdrawal, but discontinuation in that scenario is just not accurate.
Okay, thanks for that comment. And I'm really grateful for your presentation, and a lot of participants and us as well are wishing you well and hope you feel better, and this bad virus will not stick for too long.
Thank you.
Yeah, thanks for that. Thank you for coming here and speaking, and I hope we can release you now to have some well-deserved rest, and that this will help.
Thank you very much. Thank you. It was an honor. Thank you for the invitation. I think that's very important. Even, I admit, it's controversial, but we need to talk about that. It's not by ignoring it that it will solve the problem. It's just by addressing it and doing the research we need. So even though some things that I might have told may turn out wrong in the future because we have strong data to refute them, then I'm happy, but we need the data. So that's why it's important to talk about that, to conduct the research it needs.
Thank you for stating that we need to face reality as it is.